So I'm here today with Professor Chad Cook. Professor is Vice Chief of Research, I believe, at Duke University. We're going to be talking to Chad today about lumbar examination. So hello, Chad.
Hello.
Thanks for joining us, and thank you for having a chat to us about lumbar examination. Before we start on the nitty-gritty, maybe you'd like to just introduce yourself to the people that are listening, just so that they know a little bit about you and where you come from and things.
Sounds great. First of all, thank you very much for having me on. I am from the United States. I'm a professor at Duke University. I have a research role here. I have been at a number of universities, Texas Tech, Walsh University, but have been primarily in an academic role at Duke University. I study a lot of different things. My research is primarily in spine, but I also study manual therapy a good bit. I am a senior associate editor for the British Journal of Sports Medicine and a special topics editor for JOSPT. So I love the whole publication gamut and how information gets out to learners.
Great, that's great. So a full-time research involvement role. I read on your biography on your Duke University website that your passion is for refining and improving the patient examination process. So I'm hoping that we can tap into a bit of that passion today with talking to you about the lumbar spine. So can we start by just talking, I'd like to ask you, do you have a particular sort of structure that you consider when you're examining the lumbar spine?
I do, and it actually was born out of teaching and teaching new learners how to address the lumbar spine because it can be so daunting when you first look at it. But I follow a logical structure of essentially looking at the patient and considering really the epidemiological elements of that person first, that their demographics, the how long they've had back pain, that sort of thing. And then I follow along a consistent line of thinking. I do a comprehensive patient history, observation, a detailed movement examination. I will consider some special tests, and the things I wrap into special tests tend to be either triage related tests or confirmatory tests. And then I consider the prognosis of the patient by looking at a number of different components that came up during the examination that I know may either accelerate the recovery or actually delay the recovery. And then at that point, I am able to decide where that particular person should fall within the treatment cycle, what classification I might consider putting them in.
So you've mentioned a few things there as part of that sort of structure. I'd like to, if we can, just cover a few of those. You mentioned demographic features, and what are some of the key demographic features that you feel are important in low back pain?
Well, I want to mention that there are there are heaps of studies on these, and you're never going to find. I think I looked at last week. I looked at some work on this, and there were 65 different studies on epidemiological contributors to low back pain and or demographic features. And you'll never find all studies agree upon one thing, but there are trends, and certainly older age is related to poorer outcomes. Females tend to have poorer outcomes than males in the majority of studies, not all. Certainly chronicity affects, you have to consider that piece because it can send you down a different road with respect to low back pain. Some of our work has actually looked at prior low back pain as a contributor for continued recurrent low back pain. You have to consider the occupation, social situation of the patient. One of the big things that I always look at is presence of widespread pain in an individual because that could mean a contribution of neural related structures. And then other components such as, just the emotional aspect of the patient, the amount of distress that they're in about their current condition, their own expectations of recovery, their ability to cope with their current problem, and certainly the pain behaviors that the patient exhibits during their examination. So all of these things are kind of wrapped into a lot of disparate ideas, but are all things that I look at when I encounter that patient. And it really carries forward through the whole physical examination piece, but I always consider these elements.
You mentioned that it carries forward through the whole physical examination, but I imagine most of that information comes out of the subjective sort of questioning that we do at the beginning of the examination.
It does, and a lot of it can come out of if you take if you have an intake form that you give a patient prior to actually seeing them, which I would recommend tremendously because it cuts time out dramatically. But actually finding the insurance status of the patient and and just looking at some of the things that may contribute, like the amount of comorbidities that they have. And I know there are mixed research on this, but there is there's enough information that's been published to at least recognize this as being important. Some of our recent research has actually looked at risk stratification for low back pain, neck pain, and other areas of the body, and there is consistency. And I just want to touch on that, if you don't mind, that the insurance stratification, especially in Western countries like the United States, if they're on workers' compensation, or if they're on accident insurance, or if they're in litigation, which we run into a lot here in the United States, it seems that no amount of intensity of care changes these individual status. And these are important things to recognize, especially in a health services perspective, and whether we want to spend a whole lot of money on trying to have individuals recover, or the type of efforts that you put into the care of a patient.
And yeah, good. And that all comes through from our questioning. It's really interesting about the insurance side of things and litigation side of things as well. I was just wondering, you mentioned the intake form. Is there any openly available sort of general intake forms that are available online for people to use?
I've seen so many just by Googling patient intake form. What I would recommend is something that captures medications, something that captures the amount of other health related problems, something about their occupation, uh, but also something that maybe keys in on the patient's own perception of their pain related problem. I can't really recommend one, but I know that you can most likely find a number of them. I have a textbook that's actually case-based, and within the textbook, we actually incorporate a patient intake form as part of that case history. And the way we built that form was actually by looking at examples that we saw from a number of clinics that we pulled from by Googling it. So I think tailoring it to the patient population that you have in your clinics is important, but I would definitely look for a number of factors such as patient's perception of their own condition and the comorbidity piece.
That's great. What's the name of your textbook so we can have a look if we want to?
Yeah, it's 100 orthopedic patient cases. It's I have 3 textbooks now. I'm not trying to hawk my textbooks, but the reason we created the cases book is because we in teaching situations we were constantly building our own cases, and we didn't know if these cases were good or bad or whatever. So we created this textbook, Ken Lehrman, my colleague and I, and in order to use it as a teaching method, and because we believe case-based learning is probably one of the most effective ways to learn, is to actually go in and pretend about that patient, but look at all of the elements that may contribute to that patient's recovery.
Good. So we'll include a link to that textbook,
Thank you.
excuse me, at the bottom of the with this audio. So we've talked about the sort of subjective examination. Maybe we could move on to the objective or the physical assessment. And so
Okay.
you mentioned that you do a movement examination. So what are the sort of things that you're looking for in a movement examination?
So there are a few, I think, very key areas with respect to a movement examination. We published a paper recently on the comparable sign, and this is a Maitland concept, and you'll hear some people use the term uh, concordant sign, and essentially it's the same thing. It's the movement that reproduces the patient's familiar sign. It's the thing that is most important to them. In our study, we found that those individuals who reproduced their concordant or comparable sign were typically associated with a mechanical problem and generally had a fairly good outcome in comparison to those who really struggled to identify a concordant sign. And to me, that makes a lot of sense when you're dealing with a patient population. If they can reproduce their symptoms and they can show you the movement that reproduces the symptoms and you can affect that concordant sign, then you're probably going to have a good outcome. And those individuals that you can't do that with, you know that you're probably going to be dealing with something perhaps a little bit differently. I also look at uh, a within and a between session change. So the concept behind this is, are there certain movements or positions or postures that you can put the patient in that either worsens or improves that individual? Again, it relates heavily toward this is a mechanical problem, and then you can work within that mechanical finding. Quite a bit of research has shown that if you can see a within session change in a patient, if you can have them do particular movements to reduce their pain, then the outcomes of that patient is actually going to be pretty good. In fact, a within to a between session change where you see a carryover effect to the next visit is a great predictor of a positive outcome. What's interesting is we're starting to see this idea of looking for change in the patient examination as a better predictor for return to sport, for other areas outside traditional low back related problems outside the spine spectrum. I reviewed a really nice paper the other day with respect to hamstring injuries. We really can't look at baseline at hamstring injuries and determine who's going to have a quick recovery or a poor recovery. But if you see a change in that patient over a 7-day period, that's a heavy predictor of a really strong predictor for a good outcome. It's the same with spine. We have enough literature on this right now that this should be part of everybody's examination.
We're sort of getting into the realm of prognosis, aren't we now, which you also mentioned, but I might come back to a prognosis in a moment. But before that, are there any sort of special tests that you feel are really truly useful for the assessment of low back pain?
So for those that are familiar with special tests, they'll know that there aren't as many special tests in the lumbar spine that you might find in the shoulder or the sacroiliac joint or something of that nature. So we're not inundated with 2,000 shoulder labral tests like in the lumbar spine like we are at other areas. When we look at special tests, I like to divide them up to those tests that maybe are triage associated. So they're good for ruling out other conditions. And then those tests that maybe are good for confirming a condition that you built your hypothesis through that physical examination. So for the triage, there are a number of potentially competing conditions that will masquerade as low back pain. Certainly things such as the hip, and I often use the hip scour to try to rule out the possibility of a hip. You have to rule out either a neurological or a vascular contribution. So things like a straight leg raise or looking at dedicated findings associated with stenosis, or maybe the treadmill test or the bike test is good for identifying vascular related problems that cause low back related leg pain. For sacral fractures, which also mimic low back pain, you have to look at things such as an osteoporosis history. Have they had pelvic radiation therapy? Do they have RA, long-term corticosteroid use? Are they an underfed runner that maybe has changed their training lately? And you may think they have low back pain, but it's actually a sacral fracture. Sometimes the sacroiliac joint is misdiagnosed as low back pain. There really aren't any triage tests that are good for ruling out the sacroiliac joint. And I know a lot of people have considered the use of Lazalet's cluster for this, but it wasn't really built for that. It's more of a confirmatory test. And even I think Mark Lazalet would support that as well. Now those tests with respect to confirming a condition, let's say you have I forgot one, by the way, straight leg raise. That really should be used to rule things out. It's not a confirmatory test whatsoever. So that rules out lumbar radiculopathy. It certainly does not rule it in. If you're interested in ruling in lumbar radiculopathy, this is where your traditional neurological screening tests fall. Things like reflex testing, sensibility testing, manual muscle testing. Those tests are certainly more specific and they have higher positive likelihood ratios than they are sensitive. And they should be used near the end of your examination to confirm something that you saw during your examination. Maybe some of the endurance testing falls in here as well. Maybe you have suspicions that you're dealing with someone that may have stability aspects. And then Luciano Machado published a paper recently that looked at the lumbar spine instability scale, which may be useful also to confirm the presence of stability problems in that particular patient, prompting you to consider going down the route of stabilization strengthening for your patient. By the way, the last thing that would fit within this confirmation piece, I think, would be imaging. And traditionally, imaging in most health practices, especially non-socialized practices, I think, imaging is used too much, and it's often used very early in the examination to try to get an understanding of what's going on with the patient. But imaging should be used to confirm what you identified in your clinical examination. And there's quite a bit of literature out there to actually support that.
So how do you decide who you send for imaging?
Well, that's a great question. So my feeling is this: when I consider sending someone out for imaging, I have an underlying thought process that this may not be a good candidate for physiotherapy. And so I have concerns, and I'm dealing with something that's outside my realm of how I can actually help that patient. In that case, I think, okay, this patient either has some sort of sinister problem, or maybe they're a surgical candidate, or maybe they're a candidate for injections. So if we think about a sinister problem, then maybe we're dealing with a tumor or a fracture, and those particular individuals are going to behave differently during your clinical examination than someone who has a pure orthopedic mechanical problem. A person with a tumor, you're still going to be able to reproduce their pain, by the way. And we showed that in a relatively large retrospective study that we published in Pain Practice. You can still reproduce individuals with, for example, metastatic spinal cancer. You can reproduce their pain, but the behavior of that pain, once it's reproduced, isn't the type that's going to decrease with repeated movements or different postures or something like that. So it doesn't behave in a way that's mechanical, which we traditionally see as physios. Things such as fracture, that'll be similar to that too. And then you always have to consider the whole mechanism of injury and all of those elements. With respect to identifying who might be a better surgical candidate, there are quite a few randomized controlled trials that compare a conservative approach to a surgical approach. And in many cases, the physio in the conservative approach is more of a smorgasbord of care. It's not necessarily good or guideline based or anything like that. But in most cases, the results are equivocal between the two groups. If you look at the surgical and determining who's a surgical candidate, we have done some work recently in this. We presented this at CSM, and we've just published a couple of papers, one in HSSJ and another one in International Orthopedics. And it suggests that those individuals that have significant leg pain greater than back pain and who are older tend to be good candidates for surgery. It suggests that individuals who have underlying psychosocial problems, the same type of psychosocial problems that we have as physios, they don't do as well with surgery. Now, there needs to be more research looked into this, but I always consider how bad is the individual's leg pain with respect to their back pain, and how much is that contributing to their function, and whether or not this individual is going to be a candidate for possibly surgery before I would refer them out for that.
So you've talked a little bit about, that's really useful to talk about. There's always the big question about who do you send for imaging, and I think we think that people get sent too much for imaging, so it's good to listen to you talk about that and have an idea of how we should approach that sort of thing. And you've talked about sort of some of the things we would refer on to another speciality, and that's with the tumours and fractures and things like that. I assume you consider other differential diagnosis when you're looking at someone with low back pain. So are there other competing conditions that you sort of attempt to rule out?
Yeah, I'd actually like to talk about other than the triage-related ones that I talked about before, SIJ, hip, but I want to talk about chronic pain syndrome and this misassumption about that anybody that has chronic pain is actually you have to treat them differently and all this. Certainly, there is a patient population that has had back pain for a very long time that maybe has central sensitization or maybe has um, a distribution change within their brain with respect to how they perceive pain. And and we've heard this term sometimes chronic pain syndrome. And the idea that a person should be treated differently because they have now widespread pain, very, very small activities really amplify their report of pain, high levels of disability, and they have this overlying psychosocial problem. So with respect to conditions I might consider referring out or conditions that I differentiate between your garden variety mechanical low back pain, it's this population. And I think it's a difficult population to really differentiate. First of all, I still do a very robust physical examination because in many cases, individuals who have chronic problems just haven't been treated very well. And maybe they just need good physio, and then all of a sudden the problem starts to diminish. But on individuals that we know have received quite a bit of care and good care, but still have problems, then we may need to address them differently, and that's your chronic pain syndrome group. And there are a couple tools that I like to use to really get their perspective on things, because we know when it comes to predicting outcomes, the patient's expectations and where they are within their readiness to change will dictate their recovery process dramatically. So I like the pain stages of change questionnaire. It has really 4 domains, really 3, but it says it has 4, but it has pre-contemplation, contemplation, action, and maintenance. And if a person scores in the pre-contemplation and contemplation phase, then they're really not at a place to maintain their own care, to take charge of their own care, to manage their own condition. And then the pain beliefs and perceptions inventory is another one I like to use because it actually puts a qualitative um, overlay on a patient's condition where they see their pain as a mystery, or if they have self-blame, or they report pain constancy or permanence. Those things are very, very telling on where your patient is and their road to recovery. And I don't think it is the wrong thing to do to consider the use of an adjunct health provider, such as a psychologist, to assist us when we're dealing with individuals who score very poorly on these components, because they need to be in a state that allows them to recover. And if they're not there, then no matter how good your therapy is, it's not likely to make a change with that patient. So that's another piece that I will differentially diagnose versus the garden variety mechanical back pain. And I know there are a lot of, and in fact, I think you're actually interviewing some people, Peter O'Sullivan and folks like that, that talk about how to manage this patient population. On my end of it, I'm more interested in recognizing this patient population, people that maybe have abnormal pain behaviors that you identify during observation, that sort of thing, where you have to have a heart-to-heart with these patients and really find out where they're at.
So if I was to ask you the really difficult question, probably of if there was one piece of advice that you would give to anyone in a way that they could recognize someone who you would put into that chronic pain category, what sort of thing would it be? As opposed to the simple mechanical type pain that we would be able to, acute, subacute pain that we would be able to address.
So I've heard a colleague of mine in Canada, he uses this approach, and he basically asks the patient on the first day, are you ready? Are you ready for this? Are you ready to recover? Are you ready to go down this road and take responsibility for this, because you've got a big part in your own recovery? Because if you're not ready, then you're not ready. And I want you to come back to me when you're ready. So that should be somehow in a maybe a softer fashion built into the examination to find out what the person's readiness or their own expectations of their own recovery. Because if you look at that simple question, it builds in essentially coping, self-efficacy, readiness to change, all of these pieces, which are the biggest predictors of any musculoskeletal related problem. It doesn't matter whether it's the spine or not. Those are the biggest prognostic aspects of recovery. And if a person's not ready, if they're flat out, no, I'm not really ready for this, I'll be honest with you, I'm just here because I have to be here, they're not going to change no matter what your care is. And it takes it takes away the frustration of both parties. So that's the one thing I think that I would recommend.
I like that question. I like that. Yeah, good. So that leads us back to the prognosis discussion that we were having before. We've talked about they need to be ready. We've also talked about finding a comparable sign and having a good response to treatment and a good response between treatments. Is there anything else you would consider when you're assessing sort of prognosis?
Well, when I look at a prognosis, I try to consider what are the barriers of a quick recovery for this patient. And then, of course, that's a whole different domain, right? What is that patient's interpretation of recovery? Because that could really factor into the improvement of that particular patient. But if we assume recovery is a return to whatever their prior to illness function was, then some of the other things that I look at, and I had mentioned earlier, is central or peripheral pain sensitization, because we know that those individuals are going to most likely have a more delayed recovery, and it'll probably alter the way that you treat that patient. And I mentioned it before again, but widespread pain generally means we have some central mechanisms involved. And again, it's going to alter the way that you treat the patient. It's going to really delay the recovery of that particular patient. And lastly, the psychosocial pieces. Now, the psychosocial pieces, to me, it's minestrone soup. All right. Some people are going to like some aspects of it, not others. Others, it's going to be another thing. Different psychosocial factors will influence patients differently. That's why you often get this mixed information within the literature, I think. Some of the biggies are depression, others are anxiety. But then we go back to other things such as coping, self-efficacy, and other elements. So these are the biggest things that I consider when addressing prognosis with the patient, more so than the physical piece. It sounds like I'm taking the physical examination and kind of pushing it to the side and suggesting it's not important, and that's not the case whatsoever. I will always consider a robust physical examination, and regardless of the patient, it's a necessity. In fact, in our comparable sign paper, we found that your ability to reproduce symptoms during a UPA, a unilateral posterior anterior, that really reflected the chief complaint of the patient was associated with a quick recovery. So the ability to mechanically isolate the patient's symptoms during that physical examination is essential and is a great indicator of prognosis. But because it's the low back, we have to consider those other bits that contribute to that patient's recovery.
Okay, so I think there's a lot to consider there for prognosis. I think we've probably covered quite a lot. I was just wondering, we just moved back to talking about the physical examination again there, and I was just wondering if you were to give sort of young physios, new physios, some advice on what physical skills that they should be good at to perform an examination for low back pain. What would you say to them? What would you say to them to make sure that they can do this well?
I think there are two things, and these are, I would say they're somewhat old school, but I think they have carried over on their value during the physical examination. The first one is if you can do a good comprehensive McKenzie-based or MDT-based examination, then you're going to be looking at things with a very patient and thorough eye. And I think a lot of things distill out of an examination, an active movement examination, that is that comprehensive. And the other is, and this is based on, I'm more Maitland trained, but having the ability to go in and do a comprehensive passive physiological and passive accessory examination is also very telling. First of all, it engages the patient as part of that examination process. It allows you to refine your investigation of a problem to a particular area. And we always saw this in clinical practice, that it seemed to make a difference in the outcome of the patient, and it seemed to be connected and really related to their treatment and their recovery process. But after we studied it, we really found that it did make a difference. It truly makes a difference in determining the prognosis of the patient, and it's related to recovery of that patient. So I think if I'm a younger clinician, if I'm a new learner, if I'm someone that maybe practiced in neuro and now I'm interested in being in orthopedics, you can't go wrong going to those traditional courses and not being, don't get caught up in the whole, too deeply into the philosophy or any of these things, but really recognize what you're getting from that, the true value of a patient comprehensive movement related examination of what to look for with those movements.
That's great, thank you. So we've kind of covered quite a lot of the examination there. Is there anything that we've missed out?
Well, I think low back pain examination is difficult. I really do. And I also think that we don't know all the answers, and that even the greatest clinicians will have failures, will miss things, will not know completely what they're dealing with. Just it's the nature of the beast with lumbar examination. I once went to, I've been a physio for 25 years, so in my earlier days I would jump to all the different presentations and learn all the different philosophies because I was really hungry for information. And I went to an individual who had been practicing for 30 years, and one of his comments was, I've never had a patient with low back pain that I haven't been able to fix. And I thought, wow, this guy's amazing. Well, it's a completely wrong statement. Everybody has had patients that they either can't identify what's going on with that patient, or that they don't know that person's a better surgical candidate and they should receive that, or something of that nature. And the reason for this is because there are two people involved in that examination process. There's the physio and there's the patient. And the patient has to play their role correctly in that examination. They have to contribute back and give good information and be part of that examination. It has to be a partnership for it to work. That's the thing I like so much about this great movement toward recognizing chronic pain and how to work with that patient, is because you are creating a partnership with the patient. But I think that works also in individuals who have acute mechanical low back pain, that it's a partnership and you really learn to work with the patient and show them that you're really invested in improving their particular outcome. So that's the piece I think we miss, that uh, I think it's an engagement piece. The best clinicians, I think, are the ones that really engage their patients.
That's a really good piece of advice, isn't it? To be engaging and make sure that you do engage with the patients. I know I'm jumping around a little bit, but I'm just thinking as well, when you do your examination and when you're engaging with your patients and working with them, what sort of outcome do you consider for the examination in a diagnostic kind of way? Do you try and find a pathoanatomical diagnosis, or do you find a prognostic diagnosis, or what's the outcome of your examination that you do with someone with low back pain?
Rachel, that's a great question, because I think when you try to identify a pathoanatomical diagnosis, you're going to fail in many cases with low back pain. Does that mean I don't look for one? Absolutely not. I still look for one, because that's how I was trained. That's how I think. I'm in a department here that is medically oriented. That's how we communicate. So I frequently look to see if it's discogenic, or I look to see if I'm dealing with a radicular problem, or is this stenosis, or is this a muscular problem, or is this a facet? So I look for those pieces, but I understand that my treatment will be based off classification more so than that pathoanatomical diagnosis. And there are many different classification tools that are used. I, for its simplicity, use the treatment-based classification. Now, it is imperfect. There are many holes in it. It doesn't have a piece for chronic pain. It uses triggers such as clinical prediction rules, which there are many, many problems with using those and trying to direct where a patient falls within their classification. There's more than enough literature to support that that's problematic to do that. But the thing I like about it is it frames your thinking on what type of care that patient should receive. I think it's great for new learners. I still think it's great for individuals that are long in the tooth because it allows you to really, it reduces the variability in the type of care that a patient should receive. So in the back of my mind, I will have an assumed pathoanatomical contribution, but I will rely more heavily on where I would classify that patient based off the examination results. Do they benefit from movement? Do they worsen with movement? Those sort of things help direct the traffic for classification for me. Do they exhibit radicular or neurological problems? If so, then I might consider a different treatment route based on the TBC classification. So that's how I think about it. That's how we teach our new learners to think about it. Because especially in the lumbar spine, I would say the shoulder's the same way. If you try to treat based on a pathoanatomical diagnosis of the shoulder, good luck, because the overlap in symptoms is so remarkable among the same diagnoses, or different diagnoses, excuse me. And the lumbar spine's the same way.
That's great, and I think we'll certainly be covering the treatment-based classification and just a couple of other classifications as well in the next part of this course when we move on to management. So it's good to hear you talk about that, and I think that there's definitely a move away from the pure pathoanatomical diagnosis into the more classification sort of approach, which is good. So I'm sure people listening to this will have another million questions that they'd like to ask you, but at the moment I don't have any others. So is there anything else that you would like to add to this conversation? Any last final messages or anything that you'd like to include that we haven't talked about?
You know, I think I touched on the areas that I consider when addressing low back pain. Last thing I just wanted to remind people is just because they've had pain for a long time does not mean that they need psychosocial treatment and cognitive behavioral therapy and all these other things. Really let the patient's place in their own recovery drive that more than just a chronological definition of time. I think that's a mistake a lot of people make. A lot of people make that mistake even when they submit papers, when they suggest that individuals have chronic low back pain, thus they have all these psychosocial problems. We actually don't know that. They have psychosocial problems if they have psychosocial problems. And it isn't necessarily just related to how long they've had that condition. So that's another thing that I wanted to toss out there, and I know you're going to cover that in this series, which is great because you're going to hear from, I think, some experts that really talk about how they discriminate those individuals that need that different form of care than what we learn traditionally in a physiotherapy school.
Yeah. Okay, well, that has been really useful. It's been great to hear your point of view on the lumbar examination, looking for low back pain, and talking a bit further into prognosis and and classification as well. So that's all really useful because it all ties together, and we must remember that they're not separate entities. It's all one big process. So thank you very much, Chad, for talking to us today. It's been an absolute pleasure.
It's been my pleasure as well. Thank you, Rachel.